Hello there. See some people joining. Welcome. Welcome, everybody. Let's get this started here. All right. So I'm just going to let a few minutes while others sign on here. Thank you all for joining, and I'm really looking forward to sharing a little bit more detail about navigating ocular melanoma. We've got some people signing on still. I look forward to, if you're comfortable, raise your hand. I'm happy to help in any way during this session, just to give you information and just share a little bit about what some others who have done this program have learned. All right, good. Well, if anyone joins a little later, no problem. I'm also recording this session too, so if there's anything that we talk about or there's questions that I answer specifically for you, you can go back and review the link just as a resource. So thank you for being here. This is an open house, just open Q&A to help you understand a little bit more about what navigating ocular melanoma is. So our first cohort that we had, this small group session, was almost a year ago, started January. And, I have learned I've been doing this now for 21 years as an ocular oncologist, and I have seen so many people go through this. So many people do really amazing, and seen people beat all odds. And it's not a straightforward sort of thing. It's really how you show up, the things that you learn, how you decide that you're going to accept all the things that are going on. And just with all the experience that I've had working with hundreds of patients, helping people, being there when people are having real difficult times, and also seeing people thrive and change their lives. I mean, there's so much that you can do with this diagnosis. And I just want to send a message that, when we get diagnosed with cancer, it's one of the most frightening, scary, disastrous moments of our lives. And I've had people tell me this, and I know people that I'm close to that have had cancer diagnoses, and it doesn't always have to be that way. And there are so many tools and ways to think about this and ways to get educated so that this doesn't have to be the worst thing that happens to you. In fact, there are people who, after learning things and accepting what's happening and a better understanding of the possibilities, this can really be an opportunity to look at everything in your life and figure out what you're going to do to change to make this better. And this can be difficult to do on your own, and some people miraculously are able to do this on their own. And I think that's wonderful. And it's really helpful if you have a close social support network, you have good information, you have supportive, caring doctors. There's fewer surprises, and you understand what's going on, and you understand the purpose of what we're doing. But I know, talking to a lot of people, that not every person has a similar experience, and the goal of this is to help people who really, after looking at all the information, they just want more help. They want somebody there on a regular basis to help them through this difficult journey. And navigating ocular melanoma is not only for people who are new to the diagnosis, it's also for people who have lived with ocular melanoma for a number of years, and they're kind of thinking about it. And I've had people who have been treated over 10 years ago, and they come across some information and they say, hey, I didn't even know that this is what you did to my eye. And actually, even though it's in the past, it was really helpful for me to know that this is what happened, and this is how the treatment worked, and this is why we had to do what we did. So there's all sorts of things that people can continue to learn as they go through this process. And then it's for people, we've had people in our groups who have metastatic disease. And, it's sort of like, these things happen, and we just have to face them and make sure that we are as informed as possible, and we understand everything going on. And we've had our last group, we've had somebody with metastasis, and this person really shed so much light on the condition, all the things that this person had done in their life. And it was so helpful for everybody to hear how, life goes on and we just have to do the best we can. I think that there's a lot of fear around ocular melanoma because there's so little information. And this is one of the challenges that I'm hoping is going to go away in short order, that we get lots of good information out on the internet, that there are good sites that people can go to. There are some excellent patient support groups that provide information. So it is understandable that people come into this and are completely scared because they don't even know what this is. They've never heard of it. And we're wondering, like, what am I supposed to do? And what does this mean for my life? And sometimes even reading a lot of information and becoming as informed as possible, some people just want that closer support. And so how navigating ocular melanoma works is it's a 4-week program where I meet with you for 2 hours, 1 hour on Sunday and 1 hour on Wednesday. And we go through a very curated curriculum that I put together that goes through understanding what ocular melanoma is, how we can sort of individualize some of what's happening to you so that you can put it into context and maybe you have questions. We've had people who've been treated by people across the country be part of this, and sometimes people don't have all the answers, or it wasn't explained to them how things work. And I'm more than happy to bring all of my experience and knowledge about topics that come up and help answer questions, because I really believe that the more you know about this, the better you're going to do. And then there's the fear around the possibility of it spreading, or maybe the treatment not working, or what about if I lose my vision? And what does this mean for my life? And again, this group is very helpful to not only share experiences amongst the members who join, but also for me to let you know how best to handle things. As I said, there's hundreds of patients that I've helped, maybe thousands at this point, but there are so many ways that we can still show up and be our best and have highly productive lives and be happy with this. So there's just a lot that I think people can benefit from, and I think that everybody knows what they need. And this isn't for everybody. There are people who don't like to share or be part of groups, and they may feel that they like to do things on their own and have more privacy as they contemplate all the things that are going on. I do feel that when people are surrounded by others who are undergoing the same experience or have a commonality, that there is like more benefit than just doing this by yourself. So I have seen people really lean on each other, and even just sharing the experience that you've undergone and the fact that it can help somebody else's journey is really a way that we can heal. And I think there's a lot of benefit in this. I think that a lot of times people are just faced with, what am I going to do? How do I move on? Or how do I even think about this? And this group is to help you address some of those questions and solve some of those sort of feelings that are floating around that we don't know how to handle. So I think I'm really passionate about this group. I'm looking forward to growing this and having this more available in other formats, because I really believe that going through cancer and understanding what goes on and going on this journey can be an opportunity to grow, to discover things in yourself that you didn't know you had or you didn't know you could do. And it's an opportunity to be different and to show up in a way. Nobody wants to be here, but life just gives us stuff, and we just have to accept the things that happen and then do all that we can to live with joy, to accept, to understand, and then to help people around us with our understanding and our experiences. And I think that I try to do this in my clinical practice as much as possible, but I realize it takes a lot more time, and it also requires a setting that isn't as rushed, and a setting where we can go into topics. For example, I do teach tools to help manage anxiety. I do help with teaching simple meditation practices. And then, there's so many things that we go over, and we have homework, we have things we're going to do between meetings so that we can all be accountable for everybody's progress. And I think this is part of the benefit of being part of a group of people who are moving through something and wanting to achieve something and feel more comfortable and have more confidence and be sort of unafraid to move forward and continue doing all the things that you enjoy in your life. I think that is really what I want to give to this group, and for people who feel that they're ready for something like this. Um, Again, I've received questions such as, how else can I help myself navigate? There's a lot of information that I have put out on the internet through YouTube channels, podcasts, webinars. It's all available on my website if you want to just sort of start with understanding as much as you can on your own. And this isn't for everybody. So I hope that this has given you some idea of what the purpose of this group is. It's really to help people become even stronger and have more conviction and have more purpose in what they do, so that you can continue to live your life in a very enriching and joyful way. I mean, that's all we really want in this life, is to enjoy things that are important for us and to be happy and to share and contribute with others. And I think that this is very possible, no matter what your diagnosis is. All these things are possible, and there's room for all of us to grow and to become different people from life experiences. And so my goal is to help you achieve this and to be your guide and to offer all the experience that I have to make that happen. So I would love to be able to answer any questions from people. Just feel free to raise your hand and I will help unmute you, because I think if you have questions, other people may be wondering themselves about the same issues. So please feel free to raise your hand. I want to have this sort of being informal and, back and forth. I'm happy to answer any questions you can think of. Okay, I have Diane. I'm going to unmute you. Hi, Diane.
Hi, Dr. McCamel. I have a question for you, which I've never really gotten an answer to,
Yes.
concerning the results of my tumor. And when the biopsy was done, Castle came back with a monosomy 3, an 8q gain, and basically it's saying, you really are not going to do very well with this. Then I get Castle and I'm frame negative and everything is wonderful. So it's such a dichotomy, and I've never really known how to interpret good and bad, bad and good. What does it all mean? Why? That's what I truly don't understand. I'm doing fine. I think I'm 7 or 8 years, and
Yes.
the only effect I have is the radiation caused some damage, of course. So my eye, I get the injections from Dr. Chan every 3 months, and I've got some double vision in it, and the vision's not great. But other than that, I'm absolutely fine. But that's my only really question, is what does this mean? So,
Your question is something that everybody is wondering about, because the truth is the results of the biopsy, the sort of low risk, high risk, good prognosis, poor prognosis, those are not necessarily set in stone. And, we have had many people over the years who have every single high risk marker, have the biggest tumors, have everything that you would never want to have if you had this. And they're doing great. It's like 8, 9 years later, and they're healthy and they're doing well. There's an increasing number of publications sort of zeroing in on sort of the accuracy of the tests. And what we're finding is that there are people, it's all over the map. Yes, if you have some of the, you mentioned monosomy 3 is considered high risk. There's two different ways that these prognostic tests are run. One is looking at DNA and one is looking at RNA. And the Castle test is probably the most common, just because they make it very easy to just send sample to their company. And we found that even if you're PRAME negative, class 1A, people still will get metastasis from that. And vice versa, even if you have the high risk Castle results, you may do just fine. So it is true that the more markers that you have that tend towards the poor prognosis, your probabilities of getting metastasis are higher than if you didn't have them. But we don't have any data on how long, what does it mean if you have metastasis? We have a bunch of people who have metastasis that have had metastasis for a whole bunch of years, and a lot of times not much is happening because they've found it early, they've caught it, and they're just sort of getting monitored. So what does it mean? I'll tell you what it doesn't mean. If you have high risk markers, it doesn't mean that you're doomed, you're going to do poorly, you're going to die really fast, and there's nothing we can do. So I think that that's automatically what our brains go to when we see, even when we think about the possibilities of these test results. And on the flip side, if you have everything is as good as can be, it doesn't guarantee anything either. Your probabilities of running into trouble with metastasis are less, but they're not zero. So what I've come to learn, actually we were the first center to do biopsies for prognostication. And in the distant past, I felt that, well, we need to know this for everybody because it's so important. And after a couple of decades, I realized that there's a lot of people that are doing great regardless of their test results. So what do they really mean? It's really just additional information. So you mentioned what your results were. The monosomy 3 is the piece that is a little bit concerning, but there's a lot of people who have monosomy 3 and it's been many years, like over a decade plus, with these results. And so it means that there is a possibility that your liver might be affected one day, but it doesn't mean that you are in a bad spot or things are poor. And I think there are so many things that influence whether metastasis forms or not, and it is not just the result of the biopsy. We put so much emphasis on prognosis in my field. Like I look at my colleagues and people, putting out papers and stuff. Their singular focus is how good can we be at predicting whether someone dies? And I think, it's good to have the information, but we need to look beyond that. And so there are a lot of people who have a lot of these high risk markers, but who don't have metastasis in 5 or more years. And we're not really looking at those people, like what are the factors that make things better? So, we can't really help what those biopsy results are, but we don't have to, we can choose to decide that, this is sort of out of my hands and I'm just going to do everything that I possibly can to stack things in my favor. And we talk a lot about improving your mind-body health and all the many things that you can do, because we know that whether cancer comes back or not is related to how healthy our immune systems are. What are you doing to improve your overall immune health? Are you doing all those sort of holistic things that are good for you? Because they really do matter. Really nurturing your mental health, your physical health, and working on all those things have tremendous benefit on your immune system and your body's ability to sort of fight cancer if it finds it in the body. So I think that it is not as simple as this is terrible, this is great, because nothing in medicine and in our bodies is so simplistic as that. And we just don't have tests that are absolutely accurate at knowing, because every person comes to the table slightly different. Our physiology is slightly different. How, it never ceases to amaze me how everybody does so different, even in their eyeball with the treated cancer. So, we have to take those test results with a grain of salt. We have to understand the purpose. And some people will use those test results to decide whether or not to continue doing every 6 months of surveillance screening. I recommend that everybody do 6 months surveillance screening for as long as possible, indefinitely, irrespective of the test results. Unless you have an extremely tiny melanoma that is super small, maybe, but even very small melanomas can metastasize at some point. So let's just be proactive and preventive and do all the things that we can. That was a very long-winded answer to your question, but how did, did that sort of help a little bit?
Absolutely, it did. And I'm glad you said that, because I really didn't get that any really concrete answer. It was all a bit vague, even
Yes.
to the point of one oncologist says, just ignore the negative one and concentrate on the good one. But unfortunately for me in my mind, they're both there. I wanted
Yes.
some, yes, some explanation. And I do have an oncologist and Dr. Chan who takes care of the retinas or for the injections. Excuse me. And the oncologist, he just does a liver scan every 6 months. So, everybody's doing, they're doing all of the prognostic work that's required. And basically, I'm doing just great.
Yeah.
So,
I know
yeah.
every time I see you, you're doing fantastic.
Well, I have all these other modalities at 83, but that just comes with age. But other than that, I stay very busy, which I think helps a lot. Do a lot
Good.
of volunteer work, which keeps my mind off me and my
Yeah.
mind on others. So, yeah, but I really appreciate you and your information because it is such a unusual cancer. And in fact, I actually discovered it via an MD probably 10 years before I ever saw you.
Oh,
And I just went in for an eye exam. His name was Dr. Evans up in Anacortes, Washington. He's an MD. And he told me, you have a freckle in your eye. And we don't like to, we have freckles all over our body, but in your eye is not something we like to see. So we're going to take a picture of it and we're going to watch it very closely. So he did. Fine. So then I moved to California and I told the local eye clinic here about the freckle or nevi. And so they took a picture of it and they said, oh, it's fine. They never took another picture. It was just one time and it was kind of put back in the file. Well, then all of a sudden I started seeing the flashing lights and I could tell the acuity was going in that eye. So I made another appointment with them. They looked at it again and they said, it's fine. It's absolutely fine. It's just an EVI. Then they called in another. Now, these were optometrists,
hmm.
not ophthalmologists. So he called in another optometrist. He looked at it. No, it's just fine. So I leave, but I went to the desk and I asked the doctor, the woman at the desk who does prescriptions, fills out your orders for prescriptions. So I asked her, they gave me a new prescription. So I said, would you just look at this one and compare it to last year's and tell me if any changes? So she says, oh, well, yeah, the right eye is pretty much the same, but there's a lot of changes in the left eye. So then I thought, okay, there is something very wrong here. So when I got home, I called Jules Stein, and whoever I talked to said, we'll see you here at 8 o'clock in the morning. And so then it was, of course, I was with you all day, and you told me that terrible thing, like, you have cancer. So, and then we went from there. But it really, I always think back to that doctor up in Washington was right on the ball. He knew that this was something that could change and to be very cautious and keep an eye on it. Excuse the pun. So,
Yes. We
yeah.
use that
But
a
anyway,
lot.
I'll stop talking too long.
Yeah.
So, but anyway, yeah,
No, I'm glad you follow. You just have to, you got to just follow your intuition. If something isn't right, you can't just get a new pair of glasses. You got to dig a little deeper,
right.
And I think, the way you sort of just kind of took charge and decided that you just had to call around. I mean, that's something that is very important to do in all of healthcare. So, um, one of the things that we do talk about in this program is like how to navigate our healthcare system and how do you get attention when things are happening and how do you, what are some tools or tricks that you can do so that you're just not kind of put on the back burner or your information is forgotten about. This is just the nature of healthcare. It's very challenging and it just gets more and more difficult and where it's more automated and it's so many people and things can slip through the cracks and you have to be on it and you have to be very aggressive with fighting for yourself and this is in any sphere but there's a lot of things that you can do to help make this happen and I always tell people that you have to be the squeaky wheel. You need to be that annoying patient that nobody likes it when they call so that they always serve your needs because they're like, you know what, let's just like give this person what they need so they don't keep calling and I have to keep dealing with this. You have to be the squeaky wheel because sometimes things get forgotten. You don't know who it is answering the phone. And I I tell people that you have to be advocating for yourself at all times. And if you have somebody else with you, even better. Like, if you have a partner, a spouse, a good friend, a sibling, come to appointments, in a group. Come with your
Right.
list of questions. Come with everything written out. Come with your demands that you are going to have answered and responded to, because that is how you engage, and that is how you take charge, and that is how you run the show of your own health. And it doesn't matter, you don't worry about being difficult, because everything's difficult. Even one person deciding to kind of step back doesn't change things. So you need to advocate for yourself. And part of this is just learning how to be vocal and how to get opinions, how to ask for second opinions, and how to, get people to sort of explain things to you so that you understand and that you have every single question answered. I mean, I can't say that enough. When people come to the list of questions, my fellows like, oh no, this person has like a whole page. I'm like, that's great. They're taking charge. They're going to leave with answers, and they're going to be better off for it. And so I applaud that kind of behavior. And even though people might cringe or think that's not good, you have to, because only you can look out for yourself. So you called Stein, you made an appointment, and now it's all behind you. So
Right.
I'm really
Right.
glad.
I know a doctor once told me patients have power. I've never forgotten that. Yeah,
Absolutely. You have
right.
so much power. The reason we even have changes in healthcare is because of what people want. This whole doing biopsies, I tell you, when we started, every single colleague of mine was like, why are you putting a needle in the eye? There's no medical treatment. I said, well, maybe people want to know some stuff about if it was me, I'd kind of want to know information, even though it might not change my, medical treatment. I just want to know. And I thought, I'm just going to go with that. And I don't care what the doctors think. And what happened was that there were some meetings and consortiums, and there were patient advocates who pushed to make doing biopsy for information standard of care. It would never have happened if it was
Mm,
left to the doctors to decide. It happens because people realize what's important and they make noise about it. Like if
mm,
your vision is important, say
yeah.
something. If you have to. And it's just amazing. I'm learning this is not just in ocular oncology, but in the field of OBGYN. I mean, I've had these conversations with my OBGYN doctor, and he's like, you know what? It's all patients. Doctors don't know any
Right.
better. They just keep doing the same thing they're doing. But it's when the people who start to get educated and understand, you will demand what you need. And then we have to do that. And so it's so important. Do not be quiet at your appointments. Be the squeaky wheel. It is
Okay.
critical to your health.
Thank you so much, Dr.
You're
McCannell.
welcome.
Thank
Thank
you.
you for your
Okay,
questions. All right, I
absolutely.
have Brittany. Are you unmuted?
Can you hear me?
Hi.
So I
Nice to
have
hear you again.
so I have two questions, one about the cohort and then one about the cancer specifically.
Yes.
So my question about the cohort, is that cost something that we can run through insurance, or is that just a separate out-of-pocket cost for the class, or how does that work?
So it's out of pocket. None of this is covered by medical care.
Okay.
I don't know if there are flexible health spending reimbursements that you might ask your insurance about, but this is totally separate than what your insurance covers.
Okay. And is it the same cost for your patients versus non-patients? It's just the one flat fee?
It is at this time, yes.
Okay. Okay. And then my question about the cancer, I'm a little bit confused about the ocular melanoma versus other cancers, like a breast cancer, or like, you hear of people that have liver cancer and then they just get it cut out or they have chemo. But it sounds like with the ocular melanoma, as I understand it, I read your book, and there was one point where you were talking about the PET scans, the PET CT alternating with the PET CT at PET MRI. And then you had mentioned looking for metastasis or other cancers. So then it kind of sent a thing up
Hmm.
in my head. Like, does that mean I can still get the other cancer that you do chemo for, plus get this ocular melanoma that you don't do chemo for? Like, can you kind of explain the different
Yes.
cancers? And okay.
Yeah, that's a great question. And so when what cancer is is basically a normal cell starts to, it acquires some kind of a mutation. And in the cell, the mutated cell acquires a mutation where it cannot regulate itself. So it doubles and it starts to grow, and it shouldn't be there. Almost 99% of the time in our bodies, when this happens, because this happens all the time, you have white blood cells in your immune system coming and eradicating that abnormal cell. And once in a while, the abnormal cell doesn't get picked up by the immune system, and it will continue. And this can happen in any organ, any site in the body. And there, when we talk about cancers in general, we talk about sort of solid cancers and sort of blood type cancers. Solid cancers are more where it's like a cancer in the kidney, a cancer in the eye, a cancer in the lung, a cancer in the breast. And each of these types of cancers are totally different than each other. They have different biology, they have different types of risk factors. Like, for example, people who smoke have a higher risk of getting lung cancer. And then there are special types of lung cancer that have nothing to do with smoking. So even in an organ, like say the lung, there's more than one type of cancer that can form. And so when you get diagnosed for any cancer in general, your doctor who is making that diagnosis is going to sort of tell you what type of cancer that is. And outside of the eyeball, like if you look at like breast cancer or lung cancer, everything is much bigger, and it's much more easy to sort of take a biopsy and know. Or you can tell sometimes looking at the imaging studies, like a chest x-ray or a CT or MRI, you can sometimes tell what type it is. In the eyeball, ocular melanoma is its own type of cancer. It starts in the eye. It has nothing to do with any other types of cancers people might have. And it's possible for one person to have more than one type of cancer show up in their body. For example, a person who gets ocular melanoma might 20 years later be diagnosed with breast cancer, because whether or not you have one type of cancer or the other is usually based on different risk factors. So when you talk about ocular melanoma itself, it has its own behavior that is very different than, say, getting breast cancer or getting lung cancer or prostate cancer for men. Each of these have a totally different profile. Like there's a different book for each type of cancer and how it behaves, how it gets diagnosed, and the treatments for it. You know, many types of cancer are bigger than the eye. So say like breast cancer, for example, your treatment will depend on the type it is. Maybe if it's spread to the lymph nodes, that will increase the sort of severity of the cancer. And then in many cancer protocols, you will also be treated with additional chemotherapy, not just surgery to cut it out. Just going right to ocular melanoma, we don't offer chemotherapy up front. Certainly today, at this moment in time, the current treatment really is kill the cancer in the eye so you have local control, because you don't want it just to keep growing in the eye because it will eventually mess up your eyeball. You want to kill it while you got it so you can maintain as much of the eye and vision as possible. And then with ocular melanoma, like all cancers, wherever they start from, have the possible risk of spreading elsewhere in the body. And in some cancers, it may be lungs, it may be bones. For example, if you have skin melanoma, which is different than ocular melanoma, the risk of metastasis, the cancer can spread really anywhere. And so a lot of people with skin melanoma may get head-to-toe scans as part of their ongoing care. In ocular melanoma, if it ever were to spread, for reasons we're still trying to understand, it tends to only go to the liver primarily. So doing scans of the abdomen are important. And so we do those scans because we know that if in the future it were to metastasize, it tends to go there. And then the purpose of doing those scans is for early detection. Because if we find ocular melanoma that has metastasized early, then you have many more treatment options available that can work, as opposed to if you don't do any screening or scanning or if it's found late. So just because you have ocular melanoma, we use the nature of how we know that cancer behaves to help determine the best treatment. And at this time, we don't give people chemotherapy or systemic drugs for this type of cancer. Um, there's a lot of ongoing research at the moment where there is a drug in trials where people are getting something up front, where they take it continuously to see if it will help. We still don't have we still need more time to know how helpful that is, but keep in mind that every systemic chemotherapy also has side effects too. And so for the many years we've known about ocular melanoma, there are many people who don't get metastasis. So if we gave everybody chemotherapy up front and had people on stuff for like a sort of indefinite time, there'd be probably a lot of unnecessary side effects for all the people who aren't going to run into a problem. So then we look at things like, how big is your tumor? What are your markers? Like are you more high risk or not? And then those, knowing that, if you have more high risks, then perhaps your oncologist, the doctor for cancer of the body who does the screening, will be more vigilant, will maybe continue doing tests. I know that some people have oncologists who will do scans every 3 months. We don't have good data on what is the best way to screen or scan. Currently, we generally recommend that everybody, low risk or high risk, get a scan every 6 months. So you always are checking in and you're always ahead of things. And if it ever does spread, it won't be, you won't have waited for you to have symptoms. And if we do find signs of spread, then we can immediately come up with a plan to eradicate the disease in the liver or wherever we might find it. Does that help answer your question?
Yes, it does. I guess I had a friend that had regular liver cancer, whatever regular is, where there was spread, and they just cut out a part of his liver. They said you could just cut out like 20% and it'll regrow. Is that the same kind of thing that happens if the ocular melanoma gets to the liver, or does it spread in a different way?
So if a person with ocular melanoma has the cancer go to their liver, it usually starts very focal. Again, this is if a person is getting regularly screened and it's not sort of growing without anybody knowing. So if you can catch it, sometimes surgical resection is possible, but from what I understand, it's much more common to use sort of interventional radiology. So basically use like specialized x-rays and kind of zap it without having to cut open the abdomen and cut out the liver. We can destroy pieces of the liver using radiology. And interventional radiology is that whole branch where you can target like physical locations in your liver and wipe those things out because your liver can still work well even if some of it was damaged.
Okay. Yeah, I think I have like a higher fear because I have an autoimmune disease. And since it's your immune system that takes care of the cells, it's just, yeah.
So, we don't have, certainly anecdotally, it hasn't been my experience that people with autoimmune conditions have more problems with cancer. In fact, there's some like conjecture in the medical field that people who have autoimmune conditions have lower risk of cancers in the body because their immune systems are in hyper overdrive because they're kind of attacking themselves more than they should be. But this is just, from my knowledge, I don't think there's any science behind it, but there is some like casual conversation about people noticing that maybe people don't get cancers as often because their immune systems are in overdrive. So, but this we don't know, but I don't think you're at any increased risk just because of having autoimmune condition.
Okay, thank you.
Did you have any other questions?
I did, but I don't want to take the whole.
Okay.
One more. When you talk about like if a tumor is tiny or super small, it has less of a chance of metastasis. Like, what are the numbers? Like, I got a little bit confused because I went in my portal and I was looking at like the size of the plate that was ordered, and my plate was 15 millimeters, and it said my base was 8 millimeters, but the height was 2.66. So I kind of was like, But then when I chat GBT'd, it looked
Yes.
like I was like on the border of small, medium with like one type of something and then another thing that was a calm something said I was a small and I'm like, what am I? And like, what is tiny or what is, I guess I'm confused about what the size is.
Yeah, no, definitely whenever we get a diagnosis of like cancer, we always want to know, like, it's just your own curiosity, like, where am I in the spectrum? Am I like average or what? And I think that the definitions that the COMS, that stands for Collaborative Ocular Melanoma Study, which is a really big trial that was mostly in the 90s, um, that showed that basically there's no benefit to cutting out your eye. That's the bottom line. So we always save the eye when possible. And it kind of came up with these definitions of small, medium, large. And really, it, like, cancer is and in the body, it's a biological system. So, the numbers are very man-made. We just came up with them to help categorize, to help people understand where they're at. I did a podcast on the specific staging for ocular melanoma. I might look that up because I went through some graphs because I know that a lot of people want to know what stage, where am I in this, and it's really based on how thick it is, like the tallness. And you said 2 point something, I think I heard you say, and
It
then
was 2.66, but then
yes.
apparently it grew a little bit in the couple of weeks between the ultrasound and Monday.
Mhm.
So they're leaving the plaque on for a few more hours.
Yes. So that is like, that range, you're like just borderline small medium. And then there's the sort of footprint of it. We call that the greatest basal diameter. And that's the number that we use, or I use, to determine the diameter of the plaque, because that's how much space is taking up and you want to cover all that. And there's some people feel that the greatest basal diameter is a more sensitive marker for tumor size and what that means. And basically, obviously, the smaller the melanoma is, the lower your risk of it metastasizing. That's just when we step back and look at it all. But you can have really big melanomas that don't metastasize. You can have small melanomas that metastasize. So we just have to be really vigilant always about doing the systemic screening. And I always tell people to please see an oncologist who knows about eye melanoma, so that you're not teaching that person. So, and anyone who's usually had been treated by me is also seen by Dr. Bartosz Chmielowski, who is a hematologist oncologist at UCLA, who is an expert on the West Coast in this cancer. So, even if you never need his help, which is what I hope happens to everybody, it's still great to have a person who's seen everything be the person who do the screening and to advise you and give you guidance.
Yeah. I saw him and I have my scan December 12th.
Oh, great. Good, good. And we have to, and the scans, we need to do them because it gives us information. I know over the years, a lot of people don't like doing the scans because they're very fearful about the possibility, but it's just you just have to like be okay with being scared. But we really need them to get the information to go to the next step. And if it's empty, if it's negative, there's nothing there, that is critical that you know that. And even if it shows something one day, we have to know that to know what to do next, and to sort of always be involved and engaged in every part of this.
Okay. Thank you.
All right, thank you for your questions. Anybody else have something they want to say or a question I can help answer? Really anything at all. I'm all ears. We have a few minutes. We can continue. Let me see if there's anything in the Q&A. Oh yeah, I'm just going back here. So Sandra, so good to see you. I'm so glad you joined us. Um, just on the subject of people having to look out for themselves, be their own advocates. Thank God I had Dan, who did due diligence. Having somebody along with you, like, just take anybody, take your mom or your brother or your child. You know, there's just power in numbers, because when we're in the healthcare system and you're doing something totally alone, you will naturally not want to say stuff. You'll just be like, I can't say that. And like, it's even if you have a family member that needs to go to the ER for something, like, go with them, because being in that position of being a patient, I don't know what it is. It happens to me. I'd be like, oh, I'm not going to say anything. And then you have someone with you who is like rooting for you and speaking for you. I can't say it enough. You have to do that. Let's see. Okay, question about if somebody had found a freckle long ago, would there have been anything that could have been done to prevent it from progressing? So we don't, at this time, we don't offer treatment for freckles because, like, the risk of a random freckle that's kind of small and benign, very benign, turning into melanoma is so rare. 10% of all human beings walking around have a freckle in their eye. But it's like one in 1 in 3,000 is going to change. So the only thing I recommend is that if you know you have a freckle or someone said it, just go have it looked at periodically. Don't forget you have it. Even if you don't remember what eye it's in, just remember, oh, someone said I had a freckle, and just go and get it checked every year. Just make it a routine, like just part of your regular health checkup. You also check the freckle. That's really the best way. There is really no need to go and treat every single freckle because there's so many freckles out there. There's hardly any melanoma out there. There's also some people who treat melanomas that look suspicious, but that aren't maybe for sure cancer. I'm not really, I know what treatment does, and it's very harsh when you have radiation treatment, and we save it for when you have a problem. And most times, if you have something kind of suspicious, it can be monitored, it can be watched. You don't have to just treat everything. If we did that, we would run out of space to treat the people who really did have the problems, and it's really not needed. Close observation, nothing is lost if someone observes you closely. And there's been a number of studies that show that even people who have very small melanomas, you don't need to rush the next day to get it treated. You just do everything step by step and do things appropriately. Well, I hope that this has been helpful for everybody. Make sure I'm not missing any questions here. Oh, sorry. So yes, Sandra is just talking about how her significant other helped the radiation physicist lower the dose and consider giving less radiation. So, I mean, if you have a question about your treatment, no matter what it is, bring it up. There's always never just one way to go about something, even though, there may be other options to consider and ways of doing things. And this is along the lines of just being your own advocate. After you've read and understood stuff and you have a question about a way that your treatment is being delivered, ask your doctor to say, I heard about this, what about this? And answer have your questions answered. I just can't say that enough. And ask your questions. Don't just wait or just let it go. Every moment you're in front of the experts, people who are helping you, that's your time to ask and question. Please question your doctors. I mean, nobody's 100% right. It's impossible. So get opinions, get people looking at you. Like, I can't say that enough. I think, if you're already here on this call, curious and wanting to learn more, I feel like I need to talk to the people who aren't on this call. So, but it looks like we don't have any additional questions. Let me just quickly double check. Good. Well, I appreciate you all coming, and I hope this was helpful. You can always feel free to send me an email, just if you have questions at all. I'm looking forward to doing more webinars on more information, and if any of you have topics that you are curious about or think it would be really great to have this explained in more detail, chances are you're not the only ones, and I would love to do a webinar or some sort of a talk on topics that you think are important. Well, everyone have a great rest of your weekend. Thank you so much.
Thank
Bye-bye.
you. Bye-bye.